Everyone. First of all, thank you for taking time out of your schedules and coming here. Busy week, working day. So today, for those of whom I'm not familiar with, I'm Dr. SADIQ. I'm the consultant cardiologist at Maitri Hospital, Mehdipatnam. And today we will be discussing about a very relevant topic in cardiology. A relevant topic in cardiology, something that we very often don't look at, but is a very important cause of patients coming again and again with recurrent heart failure, and that is iron deficiency. So, in this one important thing to remember here is that iron deficiency does not equate anemia. Anemia does not equate iron deficiency. In fact, in the FAIR-HF trial, which was published in NEJM a couple of years back, by Stephen Edgar et al., they showed that if you looked at patients with hemoglobins of the range of 10 to 12, around 30% of them had iron deficiency. And these 30%, when the iron deficiency was actually corrected, they showed a lot of improvement in their 6-minute walk index as well as their exercise capacity and a decrease in their readmissions for heart failure. So iron deficiency does not necessarily mean your patient should have a low hemoglobin. Your patient might have a perfectly fine hemoglobin, but they might still be deficient in iron. And this deficiency of iron is a very important trigger for recurrent admissions with heart failure. Now, as we know, heart failure is an entire spectrum. It is not only people with severe LV dysfunction and low ejection fractions who have heart failure. So it's not only these people whom we will call as heart failure patients. Patients might have an EF of 60%, but still they might have heart failure. So heart failure is a clinical diagnosis. First and foremost, heart failure, the diagnosis is clinical. Of course, we have lab tests today to corroborate. We have an NT-proBNP which will be elevated whether it is systolic heart failure or diastolic heart failure. Diastolic heart failure, today we call it as heart failure with a preserved ejection fraction. So anybody who has an EF of above 50%, they are called as heart failure with a preserved EF. Those with an EF of less than 40%, they are heart failure with a reduced EF. So you have this range between 41 to 49. That is known as a heart failure with a mildly reduced EF. Clinically they work and they function similar to patients with preserved EF. So all these heart failures, especially in the preserved EF population, iron deficiency is a very important cause of recurrent hospitalization. Patient will come, get admitted, you will give diuretic, they will get stabilized, they will go home. Again after 1 week, again after 2 weeks, they will still complain of breathlessness, still complain of PND attack, still complain of orthopnea. Until unless you look for and treat iron deficiency, you will not have improvement in such patients. So today we will discuss a couple of cases. I have run it in a case format so that it's more practical and less of a didactic talk. So this is a 75-year-old lady. She's a 26 years diabetic hypertensive who had complaint of breathlessness on exertion for the last 5 months, and she gave a complaint of feeling tired. Many of our patients come and say that Doctor बहुत थकान लग रही है, I'm feeling very weak, बेचैनी है, कमजोरी है. Many people say this, and very often we don't pay much attention to it. Especially elderly women come and say that doctor बहुत कमजोरी लग रही है. Very often you write a multivitamin and send her. So we don't really pay attention. This is a very important symptom because iron is what carries hemoglobin in your red blood cells. So if there is a deficiency of iron, there will be a tissue hypoxia, cellular hypoxia, which will cause fatigue. So this easy fatigability, profound fatigability, tiredness can be a very early symptom of patients with iron deficiency. So this patient was very critical that she has been struggling to do basic household chores and tasks. I mean, a 75-year-old lady, I was first like, okay, but why do you want to do everything? You have people to help you. But she's like, no, I was able to do everything very well last 6 months back. Now I am not able to do my daily activities. Previously I used to make food for the whole family. Now I am not able to. It's not that I don't want to, but I am not able to. I still want to do it. So she had very clear symptoms. Now, drugs wise, she was on very good drugs. She was on 20 milligrams per day of enalapril, which very rarely we see people on such target doses. In fact, in heart failure, all your studies are with 10 milligrams plus of enalapril, and she was on 20 BD, and she was also on bisoprolol. So on examination, her pulse was around 66, blood pressures were 120/70, HB was 12, and mean corpuscular volume was around 90. Her estimated GFR for her age was okay. Potassium was 4.8, but her BNP was 1320. Rest of the investigations were okay. ECG showed RBBB, and echo showed severe LV dysfunction with dilated LV, and due to the dilated LV, there was a moderate MR as well. So what would we do in this patient? So what do you do with this? So basically it's a patient with heart failure, functional class 3, and it's heart failure with reduced EF. The patient is already on an ACE inhibitor target dose and a beta blocker. So probably, of course, there is moderate MR also. Patient is actively having symptoms. You add a diuretic, a loop diuretic along with an MRA. So you add spironolactone with diuretic, and then you put her on an SGLT2 inhibitor as well. Apart from this, now what else do you do? Do you look at only ferritin? Do you look at ferritin and transferrin? Do you look at erythropoietin also? You don't do anything, or you look at a transferrin saturation alone. Now, for the diagnosis of iron deficiency, you need three, basically there are three ideal investigations: ferritin, transferrin and TIBC. But if you can't do all of these, at least do only a serum ferritin. If you have an absolute serum ferritin value of less than 100, you have to replace iron in that patient regardless. Now, if your ferritin is between 100 to 200, then you look at the transferrin saturation. And if the transferrin saturation is less than 20%, once again you have to replace iron in these patients. So ideally speaking, you need a transferrin saturation or a TSAT along with the serum ferritin. So both the tests have to be done. Many times we are, our patients have a lot of financial crunch, they are not able to afford so many investigations. So you can even get a ferritin alone, look at the value. What I do is if it's less than 200, I replace iron for these patients. So this patient had a ferritin of 105, the second category we were talking of, between 100 to 200, and transferrin saturation was less than 20%. So in this patient, what would you do? You can, of course, you will add eplerenone. Ivabradine you don't need to add because the heart rate is already 60. On bisoprolol 2.5, she is at target. CRT not right now because we have to optimize medications first. Changing enalapril to ARNI, it might help, but as of now she is on a target. If you go by the Paradigm HF trial, then yes, ARNI is shown to be superior to enalapril. So that is another thing that you can do. Oral iron versus IV iron. See, in heart failure patients, they have a lot of congestive gastropathy. So their digestion is already impaired. So if you give them oral iron, first of all, it will not be absorbed. Second thing is, they have a lot of heart failure patients also have increased inflammation. Now, hepcidin is also an inflammatory marker. So this will decrease the oral bioavailability of iron. So oral iron is not recommended in patients with heart failure. You have to give IV iron therapy. So how do you define iron deficiency in heart failure? You have to, in heart failure, in chronic heart failure, you have to go for a ferritin of less than 100 or a ferritin of 100 to 300, they have made it now. It was 200 prior, and then a transferrin saturation of less than 20%. And this is again further this numbers is confusing more. So this is the study that I was saying. This is an Indian study. Previously the FAIR HF trial that I told you from NEJM was all over the world. It was a global study. They had around close to 10,000 patients in that. This is a study from India, and they found that 76% of patients in their study had iron deficiency. And see the amount of iron deficiency without anemia, you have close to 57% patients. I have a marker here. So here the one in the box, 57% of patients had iron deficiency with a normal hemoglobin. Now if you remember in our case, the hemoglobin value was 12. For a hemoglobin of 12, we never even think that the patient can be deficient in iron. But then this patient was severely deficient in iron. So this is almost 1 in 2 patients with a normal HB in heart failure will have iron deficiency. So unless you look for it, you will not really find it. And so basically this is the pathophysiology, how it works. So what iron deficiency does is it decreases cellular oxygen storing and carrying capacity, it impairs cellular energy uptake, and it decreases the clearance of free radicals. So there is increased free radicals, increased inflammatory damage, and it will just worsen the cycle, and together this will cause a reduced exercise capacity, more amount of fatigue, worsening prognosis of heart failure, and increased hospitalization for heart failure. So this is again the mechanism. So what do they present with? They present with exercise intolerance, worsening breathlessness, increased fatigue, not able to do activity which they were previously able to do normally. And in patients with acute heart failure, it increases the risk for rehospitalization. Now the question very often is, when should you give iron? Can you give it to a patient who is admitted with acute heart failure? Generally I do not. I wait for the patient to stabilize. Acute heart failure, you give diuretics, you optimize your other medical therapy, the four pillars, now the 5 pillars of heart failure, that is ARNI, ACE inhibitor or ARB, beta blocker, MRA, and SGLT2 inhibitor plus or minus ivabradine. So you do all this, optimize them. Once they are optimized, stable, ready to go home, at that time you give them iron and then send them home. Or you call them back on their first follow-up and give them iron within a week. Okay, but in an acutely decompensated state, that is one place where you should not be giving IV iron. Once they stabilize, you can give IV iron, but make sure you give it at discharge or with the first follow-up, not later than that, because then they can get re-hospitalized with heart failure within 30 days. So this is again your event-free survival. You can see it is almost 50% lesser in patients with iron deficiency than in those without iron deficiency. And this is again a significant population where there is iron deficiency but there is no anemia, and iron deficiency per se can cause an increase in mortality, as well as it is a very important negative prognostic factor, even much more than presence of anemia. So this is again the role of exercise capacity and other things. I think we'll just skip this. This is the role of hepcidin. So what is the limitation of oral iron? Very often patients say, should I take injection? I don't want injection. Let me just take, I take oral tablet लिख दे दो, injection की क्यों जरूरत है? See, the thing is, oral iron is very poorly tolerated even in a healthy person. For those of you who have ever tried taking oral iron, you will know it causes a lot of gastritis, causes a lot of GI side effects. So it is very, very poorly tolerated. In heart failure patients who already have congestive gastropathy, it only makes matters worse. In such people, the oral iron tolerability goes down significantly. Second thing is, even if they are able to tolerate it, it doesn't give any benefit because it doesn't get absorbed. So so again, this, as I said, hepcidin is a inflammatory marker. In any inflammation, it goes up. It again goes up much more in heart failure patients. So oral iron will get blocked by hepcidin and will not have any benefit to the patient. So IV iron is used to circumvent that. Now IV iron, you have preparations. You have iron sucrose, what was there for all these years, and you have ferric carboxymaltose, which is a relatively newer molecule. Now the advantage of FCM over sucrose is that you can give large quantities of iron with a relatively lesser volume. For example, if you see your injections of injectable iron sucrose, it just comes as 100 milligrams, 200 milligrams maximum. So to reach 1 gram, you have to give around 5 such injections. But ferric carboxymaltose, you can give just one injection of 1 gram and then you're done with it. So generally in heart failures, what we do is, if the ferritin is less than 100, we give them 1 gram of injectable iron, repeat their ferritin after 4 weeks. If it is still low, we give another 500 milligrams. If it is above the range, then you just 1 gram is enough in most of the patients. So the advantage is giving large quantities with with lesser volumes and very, very minimum side effects. Okay, in fact, when compared to iron sucrose, the incidence of adverse reactions with ferric carboxymaltose is less than 50 to 60% when compared to sucrose. Now you have to remember that iron sucrose itself is a very safe injectable drug. The incidence of adverse effects with iron sucrose anaphylaxis is around 2 to 5%, not more than that. with your previous things like Jectocos and other things, you had almost 30 to 40% incidence of adverse reactions with injectable iron. But when sucrose came in, the incidence came down drastically. Hardly 2%, 3% people used to have some sort of reaction. With FCM, the reactions are much lesser than that. Maybe 1 in 10,000 somebody might have a reaction. So generally what we do, because patients ask, and many people are also scared to give injectable iron. They feel that you go take it in the hospital setting only. We will not give injectable iron. I mean, I've had patients have written iron to, and they want to take it near their house, and then nobody is willing to give it to them. They again roam the whole city and come back to take injectable iron because people are still scared. But you have to understand that FCM is a very safe IV iron therapy. The chances of having an adverse event is very minimum. But then that doesn't mean that there will never be an adverse event. Adverse reactions can happen with any drug. If you are taking even paracetamol, you can still have an anaphylactic shock. So you have to keep that in mind. And iron is something which is known to have caused anaphylaxis. So what we generally do is, when we dilute it with 100 ml, if the patient is not having severe dysfunction, you dilute it with 100 ml. Otherwise, you can even dilute 1K in 20 to 50 ml of saline. So generally, we give the initial 5 or 10 ml over a period of 10 minutes. Wait for some time, look if there are any reactions. If there is nothing, you give the rest of the drug. So that's what we normally do. And so far, we've never had any serious adverse reactions or anaphylaxis in any of our patients. One elderly ladies, they generally have some body pains, joint pains, if you give them 1 gram at a time. So in such people, you can divide it into 2 doses of 500 also. But otherwise, it's very well tolerated. And so this is another case. Now this was a 72-year-old who was going for an MRM for breast cancer, and she was a known patient with heart failure, reduced EF, and she had come for optimization of her functional status prior to surgery. Again, on evaluation, when we went about it, we found that her ferritin was around 46 and transferrin saturation was 12. So in this patient, what would you do? Of course, dapagliflozin, again heart failure with reduced EF, you can add. Ivabradine, heart rate is at around 70, you don't need to. CRT, not right now, patient is anyway going in for an MRM. What is her long-term survival? What is her long-term prognosis? You don't know. So go putting in a device worth 6 to 7 lakhs just for optimization. I wouldn't recommend. Oral iron, probably not. So I probably add dapagliflozin and then give IV iron therapy in this patient. So at the end of it, what is our take-home message today? If you remember that in patients who come with heart failure, with worsening functional status, iron, injectable iron is an emerging therapy, and in fact, it has been there for. Stephen Anker published his study in NEJM in 2018. So it's not something that is new, that has come yesterday. It has been there, but it's just that we need to be aware of it a little bit more. We need to accept it a little bit more, and we need to look for it. The commonest, drawback to iron therapy is many people still believe that if iron deficiency is there, anemia has to be there. So don't look at the hemoglobin alone. One surrogate indicator you can say, if you look at your CBP reports, you have something called as an RDW, that is a red cell distribution width. So if you find a red cell distribution width of more than 15%, it has been found to correlate with iron deficiency. So if you have good hemoglobin also, 12 grams, 13 grams, but your red cell distribution width is more, probably these are the patients you should get a ferritin done for, and if the ferritin is low, you have to correct it. So iron is safe, and iron should be looked for, and it should be corrected in all patients with heart failure. So I won't take any more time of yours and stand between you and lunch. So any doubts, any questions, I would be glad to take it. I think we can stop the talk here and we'll have more of an interactive session now. So any questions regarding the topic? Available interventions at the hospital, right from angiograms, angioplasties to pacemakers, device therapies, IABPs, TPIs, PPIs, CRTs, ICDs, everything under one roof. Even non-invasive Holters, long-term ECG monitoring, 1-week ECG recordings, tilt table tests, treadmills. We've got a new upgraded echo machine as well with tissue Doppler now. So everything that is done in a corporate center, we are able to do it lesser than any of the corporate hospitals in the city. So we are available round the clock, even acute MIs, primary PCIs, we are doing that as well. And any emergencies, we have facilities for thrombolysis as well. Pulmonary embolism, we are thrombolizing as well. IVC filters, carotid stenting, peripheral stenting. So almost every intervention that is done, we have a cath lab which is capable, fully equipped for us to be able to do any of that. So thank you again for all your support. Any queries, any doubts, I'll be glad to take. Thank you.